Thanks, the gentlelady. Gentlelady yields back, and Chair recognizes the gentleman from Georgia, Mr. Carter. 5 minutes for your questions, please.
Thank you, Mr. Chairman. Thank you, Ms. Brandt, for being here. Appreciate it very much. I want to talk to you, first of all, about abuse deterrent formulations. You know, to be quite honest with you, in my years of practice in pharmacy, when this first came out, I wasn't too high on it, but now that we've developed as much of a problem as we have with the opioids and drugs of abuse, I'm beginning to warm up to it quickly. And I see the usefulness of it and the fact that you won't be able to crush it so that you can't snort it or turn it into an injection. So I'm just wondering, I understand that, you know, there may be some cost involved, some extra costs involved, but I'm wondering what kind of barriers that your agency is seeing in using these medications and what's limiting the use to access to these types of medications.
So right at the moment, we agree that abuse-deterrent opioids are definitely a potential tool in tackling this epidemic. At this point, the epidemic is so pervasive that we are looking at any and all tools.
Exactly. I would agree with that.
We need to explore all. I think under our current statute, we cannot tell our plan sponsors what to negotiate and what types of drugs that they have to cover on their formularies. It's the plan sponsor's responsibility to do negotiations and negotiate with drug manufacturers and determine which of the FDA-approved medications to make available.
Now, who sets forth those rules and regulations? Is that in the statute?
It's under current statute, yes.
So that's something we in Congress can help you with.
You have the ability to influence that.
Okay, well, that was my next question. How can we help you? And you just answered it. We can help you by rewriting those rules and regulations to include this.
It would, as I said right at the moment, we cannot interfere in those negotiations under the statute as it's currently written. If you all were to change that, that could potentially give us more flexibility.
Right. Well, you know, as this evolves and as it continues, you know, it's certainly something we need to be looking at from a perspective here. I want to go now to the Medicaid Pharmacy Home Act, and before I ask you just a couple of questions about it, I want to compliment my colleague, Mr. Bilirakis, and his work on this. I think this is good. I've been involved during my time practicing pharmacy with lock-ins, and I see the advantage of them, but I also see some concerns. I do think that they can help lower the incidence of fraud and abuse, but at the same time, I'm just wondering in the legislation, you know, pharmacy preference is very important, and I've often wondered when these programs are used how they determine which pharmacy is going to be the lock-in pharmacy. What do you think about pharmacy preference and about the patient having the ability to request a certain pharmacy?
Well, I think, you know, as I said, we currently have this as a optional authority starting in 2019 for our plan sponsors to do lock-in. And part of it is working with the beneficiary to make sure that it's a pharmacy that fits for them, that's geographically appropriate, that is somewhere that they can access. And part of that is the right care in the right setting that I was talking about before. So I think that our expectation is that pharmacies and plans will work with the patients and the providers to make that best fit.
Well, you know, one of my concerns is access to the medication. I've seen situations where they're locked into a pharmacy, that's the only place they can get it, and that pharmacy might not have a certain product that they need, and therefore the access is denied. What do you think about having more than one pharmacy in that situation?
Well, that's one of the reasons in our world we gave some flexibility to be able to potentially have, in certain instances, pharmacies or providers, and again, trying to do so in a limited way to sort of limit the potential for abuse, but yet still be able to give those options that you're talking about.
Well, I'm glad to hear you say that, because I think that's going to be extremely important. You know, I know that the lock-in provisions can work, but I'm very concerned about, as I say, about accessibility and particularly about patient preference. That's very important, and certainly in this situation, I think it would be most important. And working with the patient to make sure that they're getting the pharmacy preference of their choice would be paramount, I think, in this situation. Well, thank you for what you're doing. Appreciate you being here today, Mr. Chairman. I yield back.
Thank you.
Gentleman yields back. Chair thanks the gentleman. Have all members of the subcommittee having had an opportunity to ask questions with the exception of the chair.